comes out of is thoracolumbar, not craniosacral. So the sympathetic supply comes out of T1 to L2. Those neurons come out into that sympathetic chain, that paravertebral ganglion, whatever you want to call them. Okay? From there, postganglionic neurons come out and supply the chest wall and the abdominal viscera, etc., to counteract the parasympathetic supply coming out of the vagal nerve. Okay? There are no cervical and sacral sympathetic neurons coming out. So they only come out between T1 and L2, but there are lower lumbar and sacral ganglion, and there are 3 cervical ganglion. Those ganglions supplied by upper thoracic and lower lumbar segments. So when they go into that chain, they do not synapse directly, but they go up and down. Those lower sacral and cervical supply the head and the arms, and the lower ones, obviously the legs. Okay? Some of those neurons that come out of these, remember what nucleus do they start at? Remember this one? The intermediate lateral nucleus, that's where they start. They come out, white ramus into the trunk, grey ramus out of the trunk onto the spinal nerves. Some of those, though, do not synapse in this trunk. They go straight through without synapsing. They go and synapse on one of these pre-vertebral ganglion or collateral ganglion. Okay, to get there, they go through the splanchnic nerves. So you have the superior and lesser mesenteric and the celiac ganglion are the 3 pre-vertebral ganglion. Okay, most of them will synapse there. Postganglionic neurons then go to all these organs that are also supplied by the vagal nerve. A small group of those do not synapse the collateral ganglion. They go straight out to the adrenal medulla. The adrenal medulla is made up of postganglionic neurons. Secretes norepinephrine. Okay? So we're finishing off last class summarizing, I think, organ by organ, how each of these things gets their sympathetic and parasympathetic supply. And what did we finish talking about? I think, what's that? Salivary glands. So which two cranial nerves get the parasympathetic supply to the salivary glands? Facial and glossopharyngeal. Okay? So you can see those on here. The otic ganglion here, and the submandibular or submaxillary ganglion for the facial nerve secrete the saliva. Counterbalancing that, how do we get a sympathetic supply to those organs? Has to come from between T1 and L2, of course. It comes from the upper thoracic, goes into the superior cervical ganglion, follows the carotid artery up, and piggybacks on blood vessels out to those various salivary glands. Okay? And that's going to cause you to secrete what type of saliva? Thick, chewy saliva. That's your sympathetic supply. When the parasympathetic supply is dominating, you're secreting very watery saliva. Okay? Let's go through a few more of these organs and see where we get the sympathetic and parasympathetic supply from. Lacrimal glands. How do we get the parasympathetic supply to our lacrimal glands for tears?
Facial nerve.
Facial nerve. Facial nerve. It's going to go through. There's 2 names for this, unfortunately. The sphenopalatine ganglion is one term for it. Sphenopalatine ganglion, or sometimes it's called pterygopalatine ganglion. Same thing. Okay? So that's where the pre-ganglion and post-ganglion neurons synapse. Post-ganglion neurons go out to the lacrimal glands. Sympathetic supply has to come exactly the same way as everything else into the head, up through the superior cervical ganglion, up the carotid artery and out along the, in this case, ophthalmic artery, down to the lacrimal gland. Okay? So sympathetic has to come from down below, because there are no sympathetic supply within our cranial nerve, only parasympathetic supply. Let's look at our viscera, our organs. Okay. Parasympathetic supply for most of these organs, of course, is going to come from our vagal nerve. Okay? Preganglion neurons are going to start in the dorsal nucleus, in the dorsal motor nucleus here, in the medulla of the vagal nerve. So the preganglion neurons start there, flood out down our vagal nerves. We've got a left and a right one. So we've got more than one vagal nerve, a left and a right. Flood out down through the whole of the upper chest, upper abdominal regions, and supply all these organs. The postganglion neuron, it's actually right next to the organ itself. You can see here in the liver, in the stomach, in the pancreas. It's right there. There's no real distinct named ganglion like the otic ganglion, whatever. They're just called intramural ganglions within the wall. So you'll see that term usually. There's no specific name ganglion for the liver, for the spleen, for the small intestine. They're just the postganglion neurons sit right there in the wall of the tissue usually. Okay, and the postganglion neuron then takes over and does what it does in that organ. Okay, note though, remember the very low organs come off S2, 3, 4 down here. So the descending colon, the kidney, the bladder, the genitalia, those very low organs, you can see them here. The uterus is supplied by neurons coming out of S2, S3, S4 segments. Okay, it's not the vagal nerve. Okay, where do we get our sympathetic supply to all these organs? Well, that comes out on those through the splanchnic nerves, the prevertebral ganglion, and then out to those organs. Postganglion neuron starts at one of those collateral ganglion and goes to all those organs supplied by the vagal nerve to counteract the parasympathetic supply coming out of the vagal nerve. The lungs and the heart don't receive supply from these splanchnic nerves and collateral ganglion. Okay, you see that? Basically the stomach, the liver, everything below the lungs comes via the splanchnic nerves, collateral ganglion supply. But if you're above the lungs, above the liver and stomach, the lungs and heart specifically do not go through the collateral ganglion. The lungs and the heart, their postganglion neurons come out of upper thoracic and cervical ganglion. You can see them here. Okay? Parasympathetic supply for the lungs and the heart, of course, comes from the vagal nerve. So that's going to constrict the bronchioles, increase mucus production. That's the parasympathetic supply. The sympathetic supply coming out of these are known as pulmonary nerves or cardiac nerves. Those postganglion neurons, I've got a better picture. You can kind of see them here, look, kind of thing. Not very well though. These are our cardiac and our pulmonary nerves, these postganglion neurons coming out of upper thoracic and our cervical ganglion. Those are the neurons that supply our heart and lungs. The vagal nerve is going to supply the heart. It's going to go on to the SA and AV nodes. You've heard of the SA and AV nodes, yes? Okay. So what effect is that going to have on the heart, the vagal nerve? What effect does that vagal nerve have on the heart? If I increase vagal tone, as it's sometimes called, whatever, what's it going to do to the heart rate? Decrease it. What's it going to do to the coronary arteries? Constrict them. Sympathetic supply, though, is going to do what? Sympathetic supply, remember, comes from our upper thoracic and lower cervical ganglion. It actually comes out between T1 and T4-5, maybe. T1, 2, C4, 5, that's where the actual preganglion neurons start for the heart. Come out into cervical and upper thoracic, coalesce to form our cardiac nerves going to the heart. They're going to counterbalance parasympathetic tone. They're going to increase the heart rate, increase stroke volume, dilate the coronary blood vessels. Okay? Remember, the heart expresses beta receptors. You've heard of alpha and beta receptors, yes? You find beta 1 and beta 2 receptors on the heart, and they're sensitive to this norepinephrine being released by the sympathetic nervous system. Okay? So you're going to find increased heart rate, increased stroke volume, more blood going to the muscle of the heart. Okay? So if somebody has too much heart rate, as it were, too much blood pressure, obviously you're going to give them a beta blocker. A beta blocker will block the sympathetic effect on the heart and decrease heart rate, decrease blood pressure, decrease hypertension, hopefully. The stomach, the digestive system, of course, that comes out of these splanchnic nerves, all these middle abdominal area, vagal nerve or sympathetic tone coming out of these collateral ganglion. The bladder is a weird one. The bladder it's hard to understand what's going on in the bladder, because the bladder gets sympathetic supply obviously out of those splanchnic nerves, those collateral ganglion, but the bladder for the parasympathetic supply, as is the low organs like the kidney and the external genitalia, the uterus, the descending colon, comes out of S2, S3, S4. And particularly the bladder is kind of it's hard to understand, because to void urine you have to relax certain muscles and contract other muscles. You have to contract the detrusor muscle and inhibit the sphincter muscle to allow urine to come out. There's a lot of, it's quite complicated how this parasympathetic and sympathetic system work on there. And I won't go into it. I know in Sandra's class we talk a lot about it in terms of spinal cord injury, because voiding urine is a big issue after spinal shock. And there's various drugs you can give to help people void. And it is a kind of complicated mess. People get what's called a neurogenic bladder. Have you ever heard of that? Neurogenic bladder. After a spinal cord injury, this is one of the biggest issues. That you just cannot empty the bladder with reflex action, typically as a reflex action, because of the messed up pathways due to a spinal cord injury. Spinal shock lesion often will lead to a neurogenic bladder where you cannot voluntarily void urine. And then, of course, you're looking at catheterization and things like this. That's a big issue. And the control of the bladder is quite complex, because certain muscles have to be excited, certain muscles have to be relaxed, and they're both influenced by sympathetic and parasympathetic supply. So it's quite, it's a poorly understood organ in terms of its control. Anything else? We've mentioned the skin, haven't we? Remember the skin, whether it be round the trunk or down the arms and legs, there is no parasympathetic supply. People forget that sometimes. They think every organ has sympathetic and parasympathetic. Every organ we've mentioned so far does. But the skin on their arms and their legs and around their chest wall does not. So the blood vessels in the skin The erector parli muscles that give you goosebumps or make your hair stand in. The sweat glands in our skin. Those do not have a parasympathetic supply. The only supply they get is sympathetic. So the amount of vasoconstriction, vasodilation is basically more sympathetic tone or less sympathetic tone. You cannot counteract it with a parasympathetic supply. Remember, arms, most of our arms are going to be supplied by the inferior cervical ganglion. Didn't show it here. Or better known, or sometimes known as what?
Stellate.
The stellate ganglion. You can see these three kind of dots here, not a terrible picture. The stellate ganglion is the inferior cervical ganglion. Not shown there. That is the one, and some upper thoracic. Not a good picture of that. Some upper thoracic ganglion also supply the arms, but most of it comes out that inferior cervical ganglion or stellate ganglion. The legs themselves, if you want to get sympathetic supply to the legs, it's going to come out of those lower lumbar and sacral chain ganglion. It's going to go down the legs and, cause sympathetic tone to the extremity, the lower extremity. These neurons just piggyback onto our spinal nerves, our sciatic nerve, our ulnar nerve, our radial nerve to get down into the hand and skin, whatever. Okay? Remember, I briefly mentioned certain patients might have a stellate ganglion block done. They'll stick a needle in there and put some drugs in to try to kill that or block the flow of sympathetic neurons going through the stellate ganglion. And what would they do that for? Complex regional pain syndrome 1. There's two complex regional pain syndromes, 1 and 2. Complex regional pain syndrome, a mess. Used to be called, probably a better name I think, I don't know why they come up with silly other terms, but reflex sympathetic dystrophy. And that tells you what it is, isn't it? It's a reflex problem with the sympathetic system. And you get this weird patterns of sympathetic tone increase in the arms. You get very, very painful joint movements, swelling, blistering, all kinds of weird things can happen. And it's a nightmare to deal with. What's the other thing that some of us might have that has too much sympathetic supply and the sympathetic afferents coming, the sensory afferents coming off these blood vessels cause pain? You've got sympathetic vasoconstriction. Too much sympathetic vasoconstriction. And people don't like the cold. Raynaud syndrome. Raynaud. You've heard of that one? Yes? How do you spell that? Raynaud syndrome. Again, that's something going wrong with the sympathetic supply. This is the people who... Has anybody got that? One, two. Usually have 2 or 3 or 4 or 5 people in a class will have some severity of Raynaud syndrome. The fingertips get very cold, the nose, the tips of the ears, the hands, and basically in severe cases you get severe ischemic pain. The blood vessels shut down so tight, it hurts. You do not get blood flow to the tips of your fingers, the tips of your nose, and they go blue. Emotional stress can cause this. Cold packs can cause this. Cold packs are a contraindication, of course, for a patient with Raynaud syndrome. You have various severities of this. In severe cases, the fingertips go blue and cyanotic. They have no O2 oxygen supply, loss of blood. And in very severe cases, patients can get gangrene. The fingertips die. And they'll rot and go black and have to be amputated. In those severe cases, they try messing with the stellate ganglion again. They try to block the stellate ganglion, stop that too much sympathetic supply to those blood vessels, causing this massive reflexive vasoconstriction of the blood vessels and the pain involved in it. Okay. So we're going to briefly sort of touch on all the organs. Let's look at some drug effects. You will get, you're familiar with Horner syndrome. You're going to review that. You know why and where Horner syndrome comes from, yes? Loss of sympathetic supply to the head, up the carotid artery. There's lesions along the neck, the lung, the apex of the lung. What's endothelioma? Eyes sink back in because of loss of sympathetic supply to the orbital muscle. Meiosis, Mueller's muscle. Ptosis, Mueller's muscle. Meiosis, what's that? Pinpoint pupil, due to unopposed action of the parasympathetic supply, right? The sphincter pupil muscle is contracting like crazy, the radial muscle is paralyzed, so that you get meiosis. Ptosis, that Mueller's muscle, paralyzed, you see this, and then you'll do that. Severe case, they'll cut that muscle out. Okay, let's look at some drugs. And many of the drugs your patients will be on will be designed to affect the autonomic nervous system. Okay? We can have, remember the hot water bath, whatever, water tap principle. You can increase the temperature of your bath, you put more hot water in, or reduce the cold water. Same thing with the autonomic nervous system. You can have something, sympathetic agonist, to increase the sympathetic activity. You can have a sympathetic antagonist, which obviously do the opposite, will decrease the sympathetic activity. Also, you can have parasympathetic agonists and parasympathetic antagonists. Okay? Obviously, a sympathetic agonist will have the same effect as what other drug on there? Which are the names? Sympathetic agonists have the same effect as parasympathetic antagonists. But the mechanism of action of the drugs is different. The overall effect is the same. Okay? To increase heart rate, for example. But the way they affect what receptors they are working on will be what might be very different. Okay? Let's look at a few of these terms. I know you get a whole class on pharmacology, but just a quick, brief introduction to some of these drugs. Sympathetic agonists or sympathomimetics, same thing. Sympathomimetics mimics the sympathetic nervous system. Okay? These you want to, of course, will increase heart rate, increase blood pressure. So you're going to give these in a hospital if the person's in the cardiac arrest, for example. If blood pressure's dropped precipitously, or the heart rate's stopped, or they're going to, have a heart attack, you want to boost the heart rate, get it going. If you're having an anaphylactic shock, for example, and your bronchioles have constricted the heck out of them, and you asthma attack, you can't breathe. You want to dilate the blood bronchioles quickly. You'll give them injection of epinephrine, for example, a sympathetic agonist, a drug to dilate the bronchioles quickly to let O2 get into the lungs. You'll give epinephrine, sometimes the drug, at wounds in the periphery, in the skin. I remember last injury I had playing rugby, I got a cleat through my scalp, and the bloke injected epinephrine into the wound. Okay? And then he put staples in my head. Why would you put epinephrine in my scalp or anybody else's wound? What's it going to do?
To cause constriction.
Vasoconstriction. Prevent bleeding, and also, because you're constricting the blood vessels and reducing blood flow, the anesthetic you put into the local anesthetic you put into the wound is not going to be reabsorbed as quickly. You want the local anesthetic to stick around in the wound site while he staples my head for a while, rather than get absorbed quickly and taken out of the site. So epinephrine is quite often used in wounds to reduce blood flow and prevent absorption of the anesthetic. Sympathetic antagonists. These are going to block the sympathetic nervous system, obviously. Okay? Very, very widely prescribed. You'll see a lot of these in the hospital. Okay, if you work in the hospitals. These often, you'll see these beta blockers. Beta blockers are sympathetic antagonists. They block our alpha and, well, so in this case, beta receptors. Prevent heart rate. So who are you going to give this to? Who's going to be on beta blockers? Who's going to be on sympathetic antagonists? What kind of generic patient? High blood pressure. Your hypertensive patients are going to be on this beta blockers. Anything ending in OLOL, suspect it's a beta blocker. So propranolol was one of the first ones formalized, invented, or whatever. Very recent, really. 1960s, James Black, a Scottish bloke, came up with this idea, and I think 1988 he got the Nobel Prize for Medicine for his work on beta blockers, and he came up with propranolol. Metoprolol is another beta blocker, acts on the beta-1 receptors, is a longer-lasting drug, but the main thing here is it's going to reduce sympathetic impact on the heart and under the organ. So it's going to block in decreased heart rate, decrease stroke volume, decrease hypertension. Be careful, when you read the patient's chart, you need to know if they're on this. If you're doing exercise, a graded exercise test or anything, you're monitoring the vitals as a patient exercises, as you should, of course, in the hospital. You take the blood pressure, get the O2 sats, right? Get heart rate before you do any of the exercises. Their response to exercise is going to be blunted, of course. They're not going to show the same heart rate response as I would as I walk up and down on a treadmill for a few minutes. It's going to be blunted. So don't expect these people to get the heart rate of somebody who's not on a beta blocker. Athletes are sometimes on beta blockers, illegally. Certain types of athletes in the Olympics are on beta blockers, and they're banned. Beta blockers are banned in the Olympics. But in 2008 Olympics, I remember Kim Jun-soo, I think his name was. He was a pistol shooter for North Korea. Anything goes there. They discovered he was on beta blockers. Why would he be on beta blockers? Why do you want a pistol shooter? It was an air pistol. He actually, I found out they took his, he got bronze in the 50 meter pistol or something like that, and he got his medal stripped when they found out he was on beta blockers. Why would a pistol shooter want to be on beta blockers? You want to reduce heart rate, obviously. Every time my heart beats, my gun goes like this, minutely. And I miss, if I have a millimeter movement of my gun here, it's 6 inches, I miss the target by. So they will shoot between heart rates, and they can monitor their heart rate quite easily, they can feel it. But if your heart rate's going boom, 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 you're excited, boom, 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 and my gun's going like this, you're not going to get the gold medal. So his heart rate was blocked. Boom, boom. Much more relaxed, and you can get them, get more medals that way. But so it's banned. So remember, the heart has beta receptors on it, and this is what's going to block. You have beta 1 and beta 2. Beta 1 you find on the atria, beta 2 on the ventricles, and this blocks the activity of these catecholamines. Have you had your beta 1, beta 2, alpha 1, alpha 2 receptors in chemistry or anything like that, biology? No, I don't think we've got time to go into that. But in your pharmacology class, you'll talk about these receptors on the heart, etc., etc. Let's not get into it. Yeah. Okay, parasympathetic agonists or parasympathomimetics, little used. You don't find a lot of use of these, I don't think. It's basically increase cholinergic activity. So cholinergic drugs, in essence, they're going to mimic the activity of acetylcholine. You'll see them where smooth muscle contraction is needed, where you want to increase, for example, activity of the stomach. Not many cases you'll see that, but maybe the bladder, you'll see it using the bladder quite a bit. You want to void urine, you want to increase the contraction of the bladder to get rid of urine. After surgery, many people have an incontinent bladder. They cannot get anything out after surgery. Shock to the system. And what they'll do is, even just a general anesthetic will have that sort of effect on you. And often they'll, before you're discharged, I don't know, any kind of general anesthetic for whatever, prostate exam, not prostate exam, but what's the thing they stick down your throat? Colonoscopy or, the other end or whatever you do. Those kind of, when they put you out for a while, they will, at general anesthetic, often patients awake, they're fine, but they just can't go to the bathroom. And they often will not discharge you until they see you have gone, as it were. And in severe cases, they'll give you a parasympathetic agonist to try to help you void urine and get over that kind of shock to the system. Parasympathetic antagonists, they're probably used more than agonists, because they, of course, are going to have the same effect as sympathetic agonists. We've talked about one before. Atropine is the one, antagonist. What do we do with that? You stick it in a person's eye, for example, to dilate the pupil, or you can, what will atropine do to the heart? Increase the heart rate. They give, atropine is, for example, used as a nerve gas antidote. So the military, going into Iraq, you think they've got nerve gases, they will carry atropine to stab themselves in the heart or whatever, if they think they've got nerve gas affecting them and they're going into a cardiac arrest. I don't want to go over all this, but you can see, maybe you can't. This is out of your text, not a very good slide, but you can see the receptor beta 1, beta 2, alpha 1, alpha 2 on one column there, and you can see the effect of the sympathetic supply and parasympathetic supply on each of the organs. That's a good review, but I don't expect you to memorize that. Remember, our alpha receptors are going to be just vasoconstriction. So remember, your alpha receptors are going to be found in the skin blood vessels. If you activate those, you're going to get vasoconstriction. Okay? When you're under stress, when you're under flight or fight response, you want to shunt the blood to your muscles and your heart. You don't care you've got blood going to the skin. Okay? So you'll see your coronary arteries dilate because they've got beta 2 receptors on them. You'll see your blood vessels in the skin constrict because they've got alpha receptors on those. The same neurotransmitter causes two different responses. Okay? So alpha receptors mediate vasoconstriction. So if you release norepinephrine onto an alpha receptor, it will constrict that blood vessel. If that blood vessel, however, is expressing beta receptors, the same norepinephrine will cause it to dilate. So this is how you get the same neurotransmitter, norepinephrine, causing two completely different things. Vasoconstriction here, vasodilation here. That's how we move blood away from the skin into the central, into the muscles, into the heart. Coronary arteries, beta 2 receptors, dilate like crazy if you hit them with norepinephrine. The skin, we don't need any blood out there at the time. We want blood for the muscles to run away from this line or whatever it is. Okay? So The same neurotransmitter can have contradictory effects depending on the receptor that tissue is expressing. Simple as that. And that's all basically in that one table there. But let's skip the details there. Okay, who controls the autonomic nervous system? Where is the control center for the autonomic nervous system? We mentioned it before a long time ago. It's the hypothalamus. The hypothalamus is the integrative center for the autonomic nervous system. The hypothalamus receives input from many different areas of the brain, from the cognition centers, from the visual system, from the auditory system, all impinge, all sense information converges on the hypothalamus. Okay? Remember, the posterior hypothalamus is responsible for increasing sympathetic activity. The anterior hypothalamus is going to increase parasympathetic activity. So that's the little mini brain, as it were, that controls the balance between a sympathetic and parasympathetic supply. Okay? How does it do that? How does the hypothalamus influence the autonomic nervous system? Well, it sends signals down two pathways. One's shown here, the dorsal longitudinal fasciculus, and, I've got a diagram perhaps here, the mammillo-tegmental tract. They're both shown there. The dorsal longitudinal fasciculus, MLF, and the mammillo-tegmental tract. Those are two pathways of neural fibers leaving the hypothalamus, descending down to the brainstem onto the reticular formation. The next thing we're going to talk about after we finish is reticular formation, but let's just reticular formation is a massive network of neurons within the brainstem. Deep within the brainstem we have reticular formation, or sometimes called reticular activating system. What pathways start at the reticular activating system? Reticular spinal tracts. The reticular spinal tracts, and there's a medial and lateral, we'll get to that a little bit today. The medial and lateral reticular spinal tracts start at the reticular formation, or reticular activating system, whatever you're going to call it, descend down the spine, and where they're going to end up then? If you're going to influence the sympathetic supply, where those are the upper motor neurons for the autonomic nervous system. That is the equivalent to the corticospinal tract for the somatic nervous system. Where are they going to end? Intermedial lateral nucleus. You can see them here, I think, on the bottom. So the medial and lateral reticular spinal tracts, part of the extrapyramidal pathway, remember, are going to come down the cord and going to land on those intermediate lateral nucleus at the segmental levels. So those are our upper motor neurons for the autonomic nervous system. So they're going to end synapse with the preganglionic neurons. They're going to come out of the segmental level, going to the postganglion, whatever. Okay? So it is the hypothalamus via the reticular formation, via the reticular spinal tracts, that goes to influencing our cranial nerves and our spinal nerves to control the autonomic nervous system. So damage to the hypothalamus, damage to the reticular formation, obviously can affect the balance between sympathetic and parasympathetic systems. And we'll talk more about that in a minute when we talk about the reticular formation by itself, in itself. But quickly, before we get to that, we've got to mention the third part of the autonomic nervous system. It's sometimes classified as part of the autonomic nervous system, sometimes it's not. The enteric nervous system. The enteric nervous system. This is a little nervous system all to its own. The enteric nervous system is a division of the autonomic nervous system that's completely outside the central nervous system. It's responsible for controlling the gut, the digestive system. It's a world unto its own. It is influenced somewhat by our autonomic nerves. The vagal nerve, for example. It's been estimated that the vagal nerve sends about 2,000 neurons to the gut. About 2,000 neurons go to the gut from the parasympathetic nerve system. Okay? But the gut itself contains 100 million ganglionic neurons. A massive, massive little brain of itself, completely anatomical and physiologically independent to a large extent from the rest of the nervous system. There are like 10 different types of neuron within this mess, within the gut. And dozens of different types of neurotransmitter. And the neurotransmitters being discovered every day that work within this stomach lining and the whole digestive system. Very briefly, there are two networks of neurons, two meshes, two networks of neural fibers within the gut. And they're shown here. The myenteric plexus, okay, and the submucosal plexus. Submucosal and myenteric, they're two meshes, networks of interconnected fibers, two layers of them that surround all the digestive system. Millions and millions and millions of neurons working together without really much influence from the central nervous system. So it's a miniature nervous system into themselves, and its job is to maintain movement of stuff through the gut. Peristalsis. The stomach basically works by itself, thank you very much, with no brain, not much brain influence. So it's an independent nervous system that controls the GI tract. There's something called the law of the intestine. The law of the intestine basically says if you stimulate the gut at any given point, you'll see reflexive contraction above that point of stimulation and reflexive relaxation beneath that point. So if I was to push on somebody's intestine from inside on any part of it, you'll automatically see constriction of the gut above there, that point I pressed on, and relaxation below. Okay, that's a reflex caused by these plexuses. That is the thing, that's the law, as it were, of the intestine that moves stuff along. That will move food down the gut with your head cut off. Okay? You don't need the central nervous system to control the law of intestine. Okay? Oh, last thing I mentioned about it. Hirschsprung disease, not a nice thing to get. You find this in children. They're born with it, where there's a problem in these plexuses. They're missing, the part of the gut is missing one of these enteric plexi. And what happens there, you cannot get dilation of the gut. There's sort of a restriction. It causes a restriction. The gut is permanently constricted at that point. And you do not get a law of intestine flowing through that area where the plexuses are absent. And so what of course you get, above that area of restriction, a massive dilation of the gut. Massive. Because food and stuff is piled up behind this bottleneck. Often called a better megacolon. Megacolon, another name for Hirschsprung disease, very serious condition. The portion of large bowel is permanently constricted, cannot relax, you get a massive dilation proximal to that restriction. And surgery is the only kind of help here. It's rare, but you see kids with that, unfortunately. Okay. Let's move on to the reticular formation, which we started talking about just there. Okay, reticular formation. It's a diffuse, interconnected mesh of neurons deep within the brainstem. The central core of the brainstem is basically a massive network of neurons. There's a lot of convergence and divergence within this network. A lot of interconnections right in here. It extends throughout the brainstem. It sends projections all up to the cerebral cortex. It sends projections down the spine. It sends projections out to cerebellum. It's kind of a linking network within the brainstem. Anatomically, we'll look at function when it does. So anatomically, there are 3 longitudinal regions within this reticular activating system, or reticular formation, whatever you want to call it. Okay. Right down the center, this red line here, is the Raphe zone. R-A-P-H-E. The Raphe zone. That's the central core of the reticular formation. Sometimes it's called the paramedian zone. The paramedian zone, another term for it. Sometimes it's just called the middle zone as well, but usually the Raphe zone is the most common term. A lot of connections go through here, connecting various parts of the brain with other parts of the brain, perhaps, but more importantly perhaps, it regulates the level of wakefulness, alertness, awareness, and we'll come back to it in a second. It also regulates pain using through Raphe spinal tract. We'll talk about that in a minute. Raphe spinal tract. Particularly important in regulating the level of consciousness, or wakefulness, alertness, whatever you want to call it. Next, outwards, going out away from the center, is we have the medial zone. Probably a better term for it is the motor zone, because this is the start, the source of our descending and ascending, primary descending tracts. Our descending tracts start in this motor zone, and of course we have our medial and lateral reticular spinal tracts starting there in this motor zone. It also connects to the cerebellum, connects to the hypothalamus above, but whatever, we'll get to that. We'll get to talk about those tracts in a little bit more detail in a minute. Lastly, on the outside, we have the lateral zone. Okay, so this is sometimes called the sensory zone. So you've got the Raphe, motor, and then sensory, or middle, medial, lateral, whatever. This receives, the lateral zone, this sensory zone, receives many collaterals from all our sensory neurons we talked about in class so far that are going up to the thalamus. They'll give off collaterals into this area. So side branches of sensory information going up to the brain are sent to the lateral zone. Okay? Alright. Functionally. So those are 3 structural regions. Functionally, what does this thing do? What does the reticular formation do? It has effects on motor control, somatic motor control. So one effect will be control of somatic skeletal muscles. Sensory control, it mediates, it can block sensations, it can regulate sensation. The second function. Visceral control, in other words, autonomic nervous system. The autonomic nervous system is controlled by the reticular formation, via those reticular spinal tracts. And the fourth function is consciousness, level of consciousness. If you damage the reticular formation, a patient could be in a coma. If you damage the reticular formation, a patient might never go to sleep. Alright, let's look at these functions in a little more detail. Motor control, the somatic motor system. The cerebellum and the motor cortex send information into the reticular formation. And emanating, starting in the reticular formation, of course, are our medial and lateral reticular spinal tracts. The medial reticular spinal tract starts more medial, as the name suggests. This black dot up here. This starts in the pons. So sometimes it's called the pontine reticular spinal tract. The pontine reticular spinal tract is another name for the medial reticular spinal tract. This is an ipsilateral tract, an uncrossed tract. It goes down one side of the cord. Okay? And its job is to facilitate anti-gravity extensors. So it's going to increase extensor tone in our limbs. Okay? Limb extension. The lateral reticular spinal tract starts lower down as the medulla. So another term for this is medullary reticular spinal tract. It's a bilateral tract. It goes down both sides. And what this does is the opposite. It facilitates the extensors, inhibits the extensors. Sorry, facilitates the flexors, inhibits the extensors. So facilitate flexion, lateral reticular spinal tract, medial facilitate extension. So they're kind of battling each other. There's a balance between these to increase or decrease flexor and extensor tone. Okay? If you damage these tracts, if you have problems with reticular formation, that balance between flexor and extensor can be damaged, can be, whacked. What happens then, for example, in a patient who's damaged this system, so, remember the flexor withdrawal reflex? I stick my foot on a pin, a thumbtack, and I pull it off. Patients who damage these tracts, they will touch something like you'll put this in my hand, and I'll withdraw my hand away from it. They can be very sensory defensive. Inappropriate touch will call a flexor withdrawal. They'll shrink away from things. Normally, I put my hand on here, I don't flex my elbow. If I stuck my hand on a thumbtack, I would flex my elbow. You'd see a flexor withdrawal reflex. But damage to these systems, these tracts, I'll put my hand down here and I'll pick my hand up. This might be something I'm not, just speculating with a sensory integration issues. You have patients like autistic patients who see kids who shy away from sensations, touch. They'll shrink away from something inappropriately, and maybe that's something to do with this balance between these lateral and medial reticular spinal tracts, causing inappropriate flexor withdrawal when it's not needed. These tracts are also thought to be important in fidgeting, keeping yourself awake. People who sit there with their leg going like that, or they're doing this, or they're constantly fidgeting with something. They're doing it to keep themselves their level of activity awake, and they're keeping themselves awake. They're constantly fidgeting with something, shaking their leg or whatever. This nervous sort of energy. It's thought these reticular spinal tracts are the ones that are causing that activity, that fidgeting activity. So that's your motor control coming out of the reticular spinal tract. Sensory control, our third function. Remember, the reticular formation receives a lot of ascending input. as sensory fibers coming in from all those sensations we talked about, particularly our painful stimulation, sensation, input into the sensory zone of reticular formation. So the reticular formation is aware of whatever's going up to the brain. It's not conscious, of course. We need to get up to the association cortex to be consciousness. Okay? But this what's sometimes called the spino-reticular tract. And these fibers impinging onto the reticular formation, spino-reticular tract. So what this allows the reticular formation to do is to send information as a result of the information, sensory information coming in. The pain, for example, pain comes in. I don't like pain. Shut it down. So our descending tracts can shut pain off at the segmental level. And it's thought that many of these come out of the right spinal tract. There's a tract coming out of the right zone. It's a bilateral tract going down both sides. And it's going to release serotonin in the dorsal grey horn. The right spinal tract is going to release serotonin as a result of pain coming in. It's going to say, wow, I don't like that. Stop it. Try to anyway. It's going to be a pain. You know, we talk about the pain gating mechanism, right? You've heard of the pain gating mechanism, where you cut off pain at the segmental level before it is allowed to ascend. And it's thought that it's the right spinal tract releasing serotonin into the dorsal grey horn to try to slow down that, decrease the amount of pain ascending through the nervous system. Activate inhibitory interneurons in that dorsal grey horn. Cut off the pain at its source, not the source, but before it gets up to the brain. So we can modulate the information coming in. It's also thought perhaps this is one of the things, you put your clothes on in the morning, I can feel them, 2 minutes later you can't feel them. We modulate sensory information at segmental level before it gets up to us. Because if we were bombarded with every single sensation of my body can feel now, I'd go mental. I'd go crazy. I can't pay attention to all that stuff. I need to damp it down. Last function, visceral control, which we mentioned. Visceral control, autonomic nervous system control. Remember, the medial and lateral reticular spinal tracts project down the cord. They project and end on those autonomic nervous system cell bodies on the intermediolateral nucleus. Remember that within the brainstem we have our cardiac center, our medullary rhythmicity center, or the respiratory center, whatever you want to call it. We have a vasomotor center. Those little reflex centers we talked about the brainstem. They're found right here within a reticular formation. And these centers decide, I want to have, increased heart rate, I want to increase whatever, breathing, I want to decrease breathing, I want to decrease diameter of blood vessels. It's all controlled by the hypothalamus, reticular formation, reflex centers, down our medial and lateral reticular spinal tract, down on segmental level. One other thing I thought about, I forgot. When we talk about motor control, these reticular spinal tracts are thought to be the ones that stimulate our neural oscillators, our central pattern generators. Remember that command neuron we talked about, gate, where we have a series of neurons. Remember that thing? Central pattern generators. You put a cat on a train when it walks, remember? Normally you don't have your head cut off when you're walking. Normally you have a command neuron coming down to stimulate that cycle, that oscillator. Okay? And that command neuron is thought to be in the medullary reticular spinal tract. So this command neuron is thought to come down in, the medial reticulospinal tract. That's the thing that gets us walking fairly automatically. I don't think about it when I walk typically. I just get on with it. So we've talked about motor control, sensory control, visual control. Last thing, probably what's most commonly thought of when you talk about reticular formation is control of consciousness. Control of consciousness. So our ascending tracts, particularly out of the wave zone, that go up to the cortex via the thalamus. So the reticular formation influences the level of activity in the cerebral cortex by influencing the thalamus. Okay? Sometimes it's called the thalamocortical activating system. The thalamocortical activating system. In other words, the reticular formation keeps the brain awake. Okay? And it regulates the amount of consciousness in the brain. The reticular formation does, reticular activating system, whatever you want to call it. Sleep is not just the absence of activity. Before you go to sleep, the reticular formation in the pons lights up. So sleep is actually an active process. The pontine reticular formation tells the brain to shut the heck up and go to sleep. Okay, it's a deliberate act to go to sleep. It's not just absence of activity. So the reticular formation keeps the brain awake, or not. Lets it, go to sleep. If you give an animal, a rat, a lesion in the pontine reticular formation, the rat will never sleep again for the rest of its life. It stays awake. It cannot sleep. If you give the same rat or its buddy a lesion to the medulla reticular formation, the rat goes into a coma and never wakes up again. Goes into permanent sleep. So the level of sleepfulness or wakefulness, consciousness, whatever you want to call it, is regulated by the reticular formation. Damage to that, can have all weird effects. And the level of wakefulness is influenced by sensory information coming into the reticular formation. Loud noises wake you up because of the reticular formation sending more wakeful signals. Pinch pain. You pinch somebody that hurts, that wakes them up. That's through the reticular formation. This is one of the things we'll test for comas. Have you heard of the Glasgow Coma Scale? Very important, very predictive scale. Made in Glasgow, in Scotland. Just briefly mentioned, this is the level of coma, as it were. This is highly predictive of how a patient's going to be after they come into the ER. I think this is in your textbook. When the ambulance people are bringing the patient into the ER, they'll call in the Glasgow Coma Scale score. It's highly predictive of the level of severity of this patient. So what it basically does is gives the three scales, the three responses: eye-opening, motor response, and verbal response. And you get a score of 1 to 4 on eye-opening, 1 to 6 on motor, and 1 to 5 on verbal. And your best score is 15. You're 15, you're okay. 3, you're in a real mess. And the likelihood of you recovering much function if you come in with a 3 is very, very limited. So, for example, we talk about pain, the best motor response. So, in other words, you'll stick a pin in a patient, he has no motor response, so pinch or pinprick, you get to 1. Okay? And then you can see there 2 is body comes, you get extensive posture. Number 4 would you pull your hand away from the pain. Number 5 is you try to grab the ambulance guy's hand or whatever is doing it. And number 6 you get if you follow commands. Okay, so best motor response to a verbal command or a painful stimulation. Eye open, you can see, 1 to 4. Do not open eyes. Up, and the best one is eyes open on its own. Verbal response, speech is number 5. Makes no noise whatsoever is number 1. Number 2, makes a sound. The examiner can't grunt in the words, whatever. So the Glasgow coma score between 3 and 15 is highly indicative of the level of severity of the brain damage of this patient. How bad a coma they're in or whatever. That's used quite a lot, you'll see, in the ER. So pain, again, is very important in alerting, in causing wakefulness. On the opposite end of the continuum, it's thought that slow, repetitive stimulation turns the reticular formation off, causes relaxation, causes sleep, causes, just mood changes. Why do you rock a baby? Why do you rock a baby? You give slow, repetitive stimulation to a baby, they'll fall asleep or relax and stop crying anyway. Have you seen patients with brain damage who rock themselves? They stand there doing this, right? You've seen patients doing that? Constantly rocking themselves, getting slow, repetitive stimulation into the system to try to calm the system down. So I'd imagine that's what they're doing. People sit on a rocking chair, very relaxing. The mood, a person's mood changes when you sit on a rocking chair for a while. I mentioned last point is silly. It's not silly, so a mate of mine who was doing sports psychology in Penn State, he did a study on rocking chairs. It was advised he wanted to do this. So what they did, it's a funny story, they come in, just like us, we'd go into this room, and you'd sit there and you'd read a magazine. One group of people would sit down in a normal chair and read a magazine. Another group of subjects would sit down in a rocking chair and rock themselves, as you do on reading a magazine. Okay? Then they leave the experimental room, that was the experiment they thought, and there would be a secretary outside the door, and she would knock her papers on the floor as the subject walked out the door. And the dependent variable was how many papers the subject picked up to help the secretary as he walked out the door. And lo and behold, if you rocked in a rocking chair while you read your magazine, you'd be much more likely to help the secretary pick up papers than if you sat and read the magazine without being on a rocking chair. Suggesting that rocking improves your mood and your whatever. Last a couple of things, then we'll stop about reticular formation. Hypersomnia is what? Hypersomnia, you sleep too much. You sleep too much. Insomnia, you can't sleep. Reticular formation problems, usually. Reticular formations. Syncope, fainting, can be a reticular formation problem. What happens when you have way too much sleep? Uncontrollable sleep, what's that called? Narcolepsy. Narcolepsy, uncontrollable sleep. What's cataplexy? Cataplexy. This is a severe form of narcolepsy. Where narcolepsy you go to sleep, cataplexy you lose all muscle tone. You basically drop to the floor, almost dead as it were. Everything shuts down. Bang! They'll fall over. Watch out for narcolepsy. Watch out for narcolepsy in your patients. Just last point too. We had a student. We're supposed to finish at what? 5-2 or 10-2? 5-2. I've got 5 minutes to tell you one story. A student of ours skied on the circuit, one of the best skiers I've ever seen. Ski instructor. Last year in PT school, she was on summer break. I was in my office. She called me up. She'd passed out in an apartment down near the Kindergarten. She couldn't get up. She couldn't get off the floor. I was the only person she knew her phone number. I went and took her to the ER. No idea what was wrong with her. It actually got worse. They thought it was MS for about 6 months. She survived the last semester of school thinking she had MS. They didn't know what it was. Then that was ruled out. She graduated. She had restrictions in her last clinical. Real mess. She was in pain throughout the body. Then they thought it was fibromyalgia or polymyalgia. Couldn't figure that out. Didn't work. Meds on that. Then she started working in a clinic as a PT. They thought it was chronic fatigue syndrome. Weird symptoms she had. Would be in pain, couldn't walk sometimes, or confused. And about a year, maybe 2 years after the initial bout of this thing, they discovered it was narcolepsy. Narcolepsy, they thought she had. Just some weird things. She would just fall asleep and whatever. They put on meds, so she now works in a clinic and she has nap breaks during the day. She can't see patients. This time, she takes the meds and goes into a dark room and goes to sleep. Uncontrollable sleep. And she gets up, she's fine. It's the weirdest thing I've ever seen, really, in terms of weird symptoms that narcolepsy in this patient came out with. So, think about it, you get some weird symptoms that's not, you know what's going on. Consider it could be narcolepsy. Or maybe chronic fatigue syndrome. It's very under-researched disease.